to our Project Echo session, Echo Dementia for July 25th. We will, people coming in, thanks for letting them in, Sammy, thanks for the record. We will engage in our usual format here. Hope you're all doing well. So just some brief opening notes and reminders. We would love to meet you if it is your first time here. And then we have the excellent good fortune of a case-based didactic by our own Dr. Daniel Fisher around neuropsychiatric symptoms and dementia, and plenty of time for discussion. I have taken a look at the slides, and I think there's so much here to talk about, so looking forward to that. All right, so some housekeeping things. If you can, are able to rename yourself so we know who you are and where you are, and also so we can keep track of who's here for CME purposes, that would be lovely. Also, it looks like everybody's muted. I am still practicing saying my name when I unmute, but work on that. If you can, your video on is always appreciated, just so we get to see your lovely face and continue to build a community here, but we know that's not always possible too. And in the increasingly rare, but still happens, scenario where there's multiple people in the room, if you could put everyone's name in the chat, again, so we can make sure we're giving people the appropriate CME credit. Speaking of which, for any University of Washington faculty, staff, or students, this is the process to obtain CME. You text that number. You're welcome to take a photo of that. And we'll also put it up at the end just for posterity's sake and make sure you get your credit. For everybody else, we record through our usual platform, and Sammy will take care of that, and she will certainly reach out to you if we need more information. We are accredited for CME through the University of Washington. We have no disclosures, neither our speaker nor the planning committee. Whenever there is a disclosure, there's a mitigation process. Had fun engaging with that at times. Some other things for your educational benefit. There's our sister program, the UW Project Echo Geriatrics, which is led by Kate Bennett team, a fantastic program that happens interstitially between art sessions. The TBI Echo, addiction psychiatry Echo. There's also some fantastic consultation services that we want to remind you of. And a repository of grand rounds, both psychiatry and neurology. So lots of great stuff out there. So let's see here. We've got, oh yes, if you are claiming CME for last year, you should have received an email from Sammy, and here's the title. We will need your request by August 1st in order to kind of fit our CME cycle here. But please, reach out. You can text me or send me a message, send Sammy a message if you have questions about that. Cases, we have had some excellent cases in the distant and recent past. We've got great cases embedded in today's visit. We are also working on making cases kind of the lowest barrier possible. It's a bit of a lift, but here's an example of kind of what you get in addition to all of the great input from our community. One of the tenets of ECHO is all teach, all learn. So we give you the summary of that, and then we're available for ongoing consultation also. So, no case is too simple, no case is too complex. All benefit from them. Again, we don't have a formal case, but in any of our discussions, making sure we're protecting PHI. There is a way to go back and edit that out, but it's better to do it proactively. And that leads to our note here that everything is on our website for your review at a later time, including all of the resources that we talk about during our cases. And then we have gotten to where we are over the last 6 years based on your feedback. Made some iterative changes that have made this program better over time. So please do take the time to fill out the survey. Really value that input. Want to make this as useful and meaningful to all of you as possible. Here's our hub team. We have a couple of our members out today. I just want to reiterate that in current times, this is just so deeply meaningful to me in that it is a cross-institutional effort. It's a rare example of healthcare systems partnering for the good of the people they take care of. So been an honor and a pleasure to be the co-lead of this since we got started. And then here are all of you. We've so far, I mean, touched about 300 providers over about 100 sites, and are actively seeking new folks to join the community. So if you have colleagues or people that you know of that would benefit from this, look them up. All right. And with that, I am going to stop sharing. And before we launch into our didactic, we've got a small enough crew here today that maybe it would be nice to do some introductions. That also helps, I think, get us rolling when it's time to start talking. So I'll start. I am Chris Rhodes. I'm a neuropsychologist and professor of neurology here at the University of Washington, and been the co-lead of this with my partner, Nancy Eisenberg, who's not here today, unfortunately, since we started in 2019. I will, to my immediate left, is Sarah McKinney. I'm going to ask you, unmute, tell us your, oh, let's do this. How about name, where you're from, and one fun thing you're looking forward to this summer. And I'll add mine is that I'm headed to San Diego next week. So looking forward to that. All right, Sarah.
Thank you. Hi, everyone. My name is Sarah McKinney, and I'm a PhD candidate in the School of Nursing at the University of Washington. And goodness, something fun for the summer is I'm kind of fun. I'm going to Northwestern in Evanston in a few months to present on some of my research and music-based interventions, and I'll be able to kind of go around Chicago as well. So I'm looking forward to that.
That sounds totally fun. Excellent. All right. Trang.
Hi, I'm Trang Lee. I'm a pharmacist at Overlake Senior Healthcare Clinic. In about 2 weeks, I'm going to the Glacier National Park, so we'll be driving there. Never been there, so I'm looking forward to that.
Nice to see you. All right. And Kimmy.
I am Kimmy DeMoto Riley. I'm a neurologist at University of Washington. I'll be going to Alaska for the first time.
Time of year to do that. So, Karen.
Hi, everybody. I'm Karen, the care partner representative for Echo Dementia. And let's see, something fun. I'm going to be hosting a bunch of people for my neighbor's 80th two-day birthday blowout on Orcas Island in a couple of weeks.
Sounds super fun. 2 days worth of celebration.
Yeah, 2 days for an 80-year-old. Let's see how that goes.
That's the right way to do it. Good for you. All right. And Hillary.
Oh, hi, I'm Hillary. I'm a nurse practitioner at the Center for Healthy Aging. I guess one thing I'm looking forward to is just whatever time I can spend with my kiddos outside on sunny weekends.
Sounds good. All right. And Sammy.
Hi, I'm Samantha LaFontaine. I'm the program manager for Project Echo Dementia, and I am looking forward to having our first kiddo. He's due at the end of August, so really excited for that.
We are excited for you, and we'll trust and hope that all goes well. All right. And Esther.
All right, there you go. It's Esther Waha. I am a family and psychiatric nurse practitioner here in Seattle, Uppercut Clinic. And fun thing is I'm traveling to San Antonio to visit my new niece. So I'm excited to go to Texas for the first time.
But should be nice and warm. Vicky.
Hi, my video is not working on my new computer, so I apologize. I am going to Indianola Days this weekend. I work at Providence Elder Place. I have for 11 years.
Excellent. Should also be fun. And then Barack is next.
I'm Barack Gester. I'm a primary care doctor and dementia expert at UW Medical Center, and I'm actually going to Toronto tomorrow for the Alzheimer's Association meeting, which will be great to just connect with lots of people that I only usually get to see on Zoom. And my uncle lives there, and so I'll get to visit him. And so it'll be definitely a vacation together with some work.
Toronto is just an excellent city overall. Very good. And Justin.
Hi, I'm Justin Wheeler. I'm faculty at the St. Peter Family Medicine Residency Program. I am looking forward to my daughter's opening show of Hello Dolly tonight. And then also doing a big backpacking trip in the North Cascades. I believe the way to pronounce it is Pasaytans in the Pasayten Wilderness area for about a week later on this summer.
Nice, up by Cathedral Peak. Fantastic. Right. Brianna.
Hi, I'm Brianna, a medical student at UW, and I'm looking forward for my garden to finally have veggies. So we're getting to that time.
Standing. Very good. And Assad.
Hi, I'm Asad Kozemi, Medical Director at Providence PACE, Program of All-Inclusive Care for the Elderly. And I'm looking forward to warm, sunny weekends here in the Pacific Northwest and traveling to Europe, not in the summer, but in September.
Good. All right, sounds good. Good to see you. And is it Alif? Am I pronouncing that correctly? It's great if not.
Almost, I respond to all variations. I'm Alif. Sorry, I don't have the video, audio only. I am a neurologist at Center for Healthy Aging. I am looking forward to going to Olympic National Park. Friends are coming soon, so I'll be taking them to represent the Pacific Northwest.
Oh, outstanding. Great place to do it. And Laura.
Hi, I'm Laura. I'm a new geriatric fellow at the University of Washington. I'm currently in memory care clinic, so I was able to get to hop on and see what Echo Dementia is about. Just moved here from the South, so excited to keep exploring all the beauty around.
Very good. Well, welcome. We're glad you're here, and glad you're here at Echo. Janine.
Hey everyone, Janine Kleiman, nurse practitioner from Providence, Elder Place. Good to see everyone. I am looking forward to some time with friends outside if it's not drizzly. And preparing for family to visit. I have to garden, which is not my favorite. If anyone wants to come over and do that. I have family visiting next week from Atlanta.
Well, I heard that come up a few times. Maybe you'll have some volunteers. Right. And did I catch you quick? I feel like somebody was here that maybe just popped off, but did I miss anybody? Nope. Christine's back. Christine, welcome back. We were just doing introductions if you want to tell us where you're at and what you're looking forward to.
So I'm a PA working at Fircrest Residential Rehabilitation Center with individuals with intellectual and developmental disabilities.
And we had Lucia here, still here. Is that who kind of we lost? But so, all right. Well, it's my pleasure. I'm going to let Dr. Fisher tell us what he's looking forward to, but it's my pleasure to introduce him. So he is one of our valued colleagues here at Memory and Brain Wellness. And Dr. Fisher completed his bachelor's degree at the University of Texas at Austin, maybe slightly less warm than San Antonio, but not much. And then went on, after some interesting post-bac experiences, went on to complete his Doctor of Medicine and Doctor of Philosophy at Northwestern. And has been here at the University of Washington as a resident starting in 2019, wrapping that up in 2023. And since then has been a clinician researcher, spending some time in memory and brain wellness. And we are fortunate that he will be providing our didactic today around neuropsychiatric symptoms of dementia. Dr. Fisher also, in my mind, is the most likely candidate to have an interesting Zoom background. Today's very professional, but I've appreciated different musicians and other things in some of our meetings. So, Dr. Fisher, I'm going to turn it over to you.
Thanks, Chris. So I'm Danny Fisher. I'm a psychiatrist here at Memory and Brain Wellness Center, and I'm definitely looking forward to AAIC, which I'm also leaving for tomorrow. But today we're going to chat a little bit about neuropsychiatric symptoms and dementia, and go through a couple of cases if we can. We may not make it to the very end and go through all the cases, and we may be focusing a lot on agitation, since that's one of the things I think that is most challenging for both families and providers, and there's a lot of discussion around it. And I will say that all of these cases, though they've been modified in various ways, do come from patients that have come in through memory and brain wellness. So these are all sort of plausible things. As we go through, feel free to ask questions, discussion. I'll try to make it as interactive as possible. I have no financial conflicts of interest to disclose. Love to have some, so you drug companies, get after me. In terms of sort of CMA things, mostly what I want to do is increase your comfort with understanding non-cognitive symptoms and neuropsychiatric symptoms that develop, knowing how to distinguish between some of the symptoms, and then have that sort of lens based on etiology of what sort of treatments that you might be thinking about, with the understanding that behavioral interventions are the first line treatment for neuropsychiatric symptoms. I'm going to do my best to repeat that over and over and over again, because I think that it can often get lost, but really is the best path forward for neuropsychiatric symptoms and dementia. We'll also talk a little bit about pharmacology for sure, and then when you might start thinking about sort of the psychointerventional services like ECT and TMS for these symptoms. So, a good clinician knows that when we're talking about dementia, when we're talking about neurodegenerative diseases, these are often things that can be affected, these cognitive domains. And, a really good physician is going to know that there are a lot of other non-cognitive symptoms that can pop up: motor dysfunction, autonomic dysfunction, tremor. But this is what the landscape really looks like when we're talking about symptoms in dementia. And all of these things in purple, these are these neuropsychiatric symptoms that can develop across a whole host of different dementias. And I'm fond of saying that if you can imagine a particular set of symptoms, there is probably a case report or more showing that there have been new onset with some sort of neurodegenerative disorder. And so it's really important for us as clinicians to know what to do, no matter, which setting we're seeing these patients in. Let's go through the first case. So a 74-year-old woman with a history of hyperlipidemia and osteoporosis presents with memory decline and attention issues. Family says short-term memory issues going back about, 5 years, progressing, and there might be some organizational issues going back even more than that. But she's seeming to also have issues with sequencing and executive function. When she's first tested in clinic, her MoCA is a 15 out of 30. And while she did have a fall with a head injury around the time of her initial cognitive deficits, the MRI showed multiple microhemorrhages that would be consistent with CAA, as well as severe white matter hyperintensities and diffuse atrophy with a focus at the hippocampus. So kind of giving you guys some of those buzzwords for some of the disease processes. And with her cognitive profile, she did have fronto-subcortical deficits, and overall was thought to have sort of a mixed dementia presentation due to the various pathologies that you're seeing: Alzheimer's, vascular, and then some of that CAA. So her mood and personality were also noted to be different from baseline, and there was concern that she had increased anxiety, would ruminate more, as well as having increased irritability. And there have been some delusions even, an increase in her demands for attention, especially from her husband. Her husband also noticed that her temper had been worse, even frightening at times, and that she was starting to sort of rock back and forth while watching TV, but otherwise there didn't seem to be any motor deficits. Over her time, her behavior started to become more challenging, and so she started to refuse care from both her husband and professional caregivers. There was verbal but not physical abuse. There were issues with disrobing and wandering. And there had been concern that she was seeing people in the house when no one else was there. She voiced even that she had these delusions where she was being physically harmed by certain caregivers, but those were never substantiated as being real. There are times when she appeared hypervigilant and would overact to even small stimuli like light touch. She often had angry responses to even the smallest of stimuli, and these behaviors were predominant during the day, but more uncommon at night. And there were occasional falls. So with this kind of history, what is, jumping out to you guys as things that are concerning, things that you might be taking into account as risk factors or other risk points when you're thinking about how you would develop a treatment plan for this type of patient? And feel free to throw stuff in the chat. Feel free to say stuff out loud. Right. There's something in the chat here. So worsening temper being almost frightening, right? So seeing sort of that angry response, and the fact that it's frightening, wondering about physical safety and thinking about follow-up questions for physical safety. So I totally agree with that. Um, I think you're also getting a sense that her neuropathological process is relatively complicated. There are certainly vascular concerns, but then there are, obviously concerns for underlying Alzheimer's disease. But though you start thinking about your interventions in pharmacology might be a little bit different if you're thinking about FTD. Definitely thinking about falls in this case, right? So we want to might think twice about certain medications that are going to be concerning. Further, we already know that with her CAA and having falls that she might be slightly at higher risk for complications with a head injury. So being mindful of that. The delusions and hallucinations. So we know that there are definitely delusions, and we know that they're distressing to her and that they're leading to potentially even safety concerns. Whether they're hallucinations, I think, is a little bit hard, right? And I think you're picking up on that our differential is broad here when we're thinking about those things. Because, well, she says that she feels like there's other people in the house. What we don't know is if she's hearing them, seeing them, that sort of thing. And thinking about psychosis differently, depending on whether they're delusions or hallucinations, I do think is important because I do think it changes both your behavioral and pharmacological approach. And then also thinking about other additional resources is really important, right? We're thinking about, again, these behavioral factors. So is part of the issue coming from caregiver burnout from the husband? Is there a good match between other caregivers? Are there other things that we can do to increase safety in the home? If there's concerns for wandering, do we think about ways that we can mitigate those risks? So a lot of really good points that you guys are bringing up. When we go back to sort of the American Psychiatric Association's, I got one more comment here. Um, so is there a sudden increase in any of these symptoms, right? So thinking about delirium. So was there a time where kind of going along normally, and then we're seeing a lot more of these symptoms, maybe difference in awareness and other sort of fluctuations in awareness that would make us think about delirium and an underlying disease. So, these are all really good thoughts when we're thinking about agitation. And I think in this particular case, there were some baseline concerns of agitation that seemed to kind of be getting worse, but definitely having these things in mind. I will say that this patient did have, did have medical testing for things like urinary tract infection, in other types of infections, electrolyte disturbances, and at that time didn't have much going on, but really smart to be thinking about these. And I think that a lot of you guys are going through a lot of what these guidelines kind of suggest, and think about, well, what was the timing of these symptoms? How severe are they? How frequent are they? Are they things that warrant pharmacological intervention? Would you suggest that only behavioral interventions be used because they're perhaps not as concerning or threatening to safety? And that's kind of a lot of the questions you're always asking is the patient distressed? If the family's distressed, kind of how much is it impacting quality of life? And then, the big one is thinking about that safety. And then you guys are, I think in a lot of ways thinking about those modifiable risk factors. And so we often think about delirium. Also remember that pain is very prevalent. Patients with Alzheimer's disorder in particular can have different perceptions of pain and probably have underreporting of pain. So some association guidelines, like the American Geriatric Association, even have protocols for agitation that occurs in dementia that start with things like Tylenol as potentially empiric treatment if there's any concerns, and even considering things like oral morphine or buprenorphine. But pain is very common. The next thing that I think won't be a surprise to you guys is that you think about sort of a non-pharmacological plan for management, and then they have some guidance on antipsychotics, along with things like think about them only in severe cases, make sure you're talking through those risks and benefits, and then always be reassessing. They recommended about these 4-month windows. But remember again, behavioral interventions, they're the most likely to work. And there have been a number of meta-analyses, and I think it's important that when we talk about behavioral interventions, that we don't just kind of have it as this buzzword of like, tell the family to do something, but what actually works? There's a lot of things that have been tried. What, in terms of the meta-analyses, have kind of come forward? I think that if you summarize everything that's in those meta-analyses, things that are person-centered and tailored, they're going to work better than a one-size-fits-all approach. I don't think that's a surprise to anyone, but having that in mind, I think, is important because what may have worked for your last patient with agitation might not work for this one. I know that that can be a very challenging thing for a lot of us, especially for primary care physicians who often are taking care of like 5 different problems that are being brought to them. But if you have a particular appointment that's only for agitation, trying to really dig into some of the triggers and things like that are going to lead to a behavioral plan that's going to outperform anything else that's going to be kind of that, again, that one size fits all. But there have been some other more specific things that have been found to be helpful. So education and skills training for caregivers has been found to be very helpful. Massage and touch, and then of course music therapy, which I believe one person here, studies a little bit. Those have all had really good signal in the clinical trials that have been done. Exercise and outdoor activities have been helpful, and even things like animal assisted or pet robot interventions, for both from the perspective of helping to combat boredom, but also increasing connectiveness and also helping to be calming. There are a number of things that are emerging and may not have a great evidence, or some that haven't worked as well. But some of these things like aromatherapy and light therapy, I think, are newer in terms of being studied and don't have as strong of an evidence base. Things for mindfulness for caregivers haven't quite worked out quite as well. Dyadic interventions don't work as well, partially probably because there can be deficits that happen with the ability to learn. Reminiscence therapy hasn't had a really great outcomes, and neither has reality orientation therapy, or basically some of what you would do with psychosis and schizophrenia, where you're asking the kind of reality test. I think that one thing that's kind of important, and one of the overarching themes that I have noticed in the behavioral literature, is that giving the caregivers and support people ways to cope and to help the patient tend to be more successful than focusing on the patient's behavior and what the patient can change. And I think intuitively this makes a lot of sense when we have somebody where learning might be more impaired for them, or they might have more issues with impulse control. So think about how to empower your caregivers and think about your behavioral interventions, especially for those who are in the, certainly moderate or severe dementia, but even mild dementia stages. Think about targeting those caregivers as your place where some of these behavioral interventions are going to happen. And then realize that despite the recommendation for behavioral interventions being first line, they're done at a pretty low clip in a lot of nursing homes. And this has certainly been my experience as well. Okay, so I've kind of hit you over the head with behavioral interventions. When we think about ways to kind of implement them, I do think that the DICE approach is just a nice framework for thinking about it. Some people really like to have this sort of thing in the back of their head. It basically stands for being able to describe the situation, investigate what the triggers are, create a comprehensive plan, and then constantly be evaluating it. And so I do believe that now this has become proprietary. And so on a professional basis, I don't necessarily endorse this as the only way, but I think it is a nice scaffold to be able to think through how you might schedule an appointment and try to get to the bottom of what could be leading to some of the agitations. Dr. Kales, who came up with this, is very fond of saying that agitation is not a disease. It's often a sign of unmet needs. And I think that she's spot on in that assessment. So thinking about those unmet needs is probably the way that you're going to get the agitation to resolve best. However, there are times when you need to treat pharmacologically, and I do believe that for the patient that we've been looking at, there's enough concern about safety, quality of life, and overall distress where we might think about various pharmacological interventions. One of the ones that I think is the most helpful are antidepressants, often with your SSRIs. So interestingly, if you look at the clinical trials for antidepressants in Alzheimer's disease for depression, they don't do very well. In fact, they don't separate from placebo in more than one well-controlled medium, at least medium-sized trial. But when it comes to agitation, there is some decent signal for reducing that. And whether that's through alleviating some of the anxiety versus reducing some of the disinhibition via 5-HT1A agonism versus um, potentially just even sort of narrowing some of the emotional range or volatility isn't quite clear. But some of the best evidence we had for this came from something called the SID-AD trial, where they used citalopram at 30 milligrams and saw a reduction in behavioral symptoms. And you'll see that in the graph on top for you guys who really love looking at data. The problem was at 30 milligrams, and as some of you guys may know, that it now has a black box warning from the FDA for long QT and sudden cardiac death in older adults for doses above 20. One thing that just recently was published that kind of put a wrench into a lot of this is that the SCIT-AD trial came out, which used Lexapro. It was interrupted by COVID, and it was complicated by a lot of baselines that citalopram use, so it was under-recruited. It also was differing from the SIT-AD trial in that they received a brief psychosocial intervention, and if they responded, they were ineligible for the rest of the trial. But there was no statistical difference in agitation on their main outcome at 12 weeks. And there was some concern that people who received Lexapro did have a greater QTC. So this has come out this year. It's something to kind of be taken into account of, well, is it that only citalopram works? For some reason, the non-racemic mixture and just the S enantiomer isn't as effective. We're still trying to kind of digest this and understand how it relates to practice, but you guys should be aware that this has sort of complicated the use of SSRIs and antidepressants in general. That being said, when you look at some of the bigger data analyses, like there was a Cochrane meta-analysis, SSRIs, both citalopram and sertraline having the best evidence, were likely to be as beneficial as even antipsychotics, which we often think of as in situations that are really concerning. So I still think that giving these medications a shot as first-line pharmacotherapy might not be a bad idea in many cases. And granted, a lot of these comes from Alzheimer's disease. When you start talking about things like FTD, then SSRIs and trazodone, do have some evidence base for those types of diseases as well. And then certainly for Parkinson's disease, SSRIs can be helpful for a number of things. It's less clear for Parkinson's disease dementia and Lewy body dementia. In a 2023 network meta-analysis, though, only citalopram came forward as being helpful. Trazodone in some small trials did not have a difference for inpatient agitation compared to Haldol, but also potentially in some small RCTs didn't outcompete placebo, though there is a positive RCT for this for FTD, though that was for more global behavioral and psychological symptoms of dementia. And then mirtazapine had a pretty moderate size, well-done phase 3 trial that found no benefit from mirtazapine. And so while I see this a lot, especially in our geriatric population, if you're trying mirtazapine for agitation, you may want to be aware that it doesn't have great trial evidence for doing so, nor does it seem to help with depression and dementia. When we looked at the there's another big trial that looked for mirtazapine for depression as well in those with Alzheimer's disease, and it wasn't effective in that trial either. We often do think about cognitive enhancers. There is some signal for acetylcholinesterase inhibitors, though we often think about those sometimes as being agitating. So a meta-analysis did show some mild improvement, but no difference between the specific agents like donepezil, galantamine, rivastigmine. I think that using them for cognitive enhancement makes a lot of sense in these diseases. Using them specifically to treat agitation, probably not as helpful. And the memantine may be helpful, but again, probably more used in its normal context of enhancing cognition. But there has been some signal in the trials for improving all large-scale kind of neuropsychiatric symptoms. And a lot of practice guidelines suggest that, again, you really want to be using these more for sort of the cognitive deficits if they're indicated. You wouldn't necessarily try them only if you're trying to improve neuropsychiatric symptoms. So now let's get to antipsychotics, that are often amongst some of the first-line pharmacotherapy. So antipsychotics, especially risperidone, are improved for psychiatric symptoms in Europe, Canada, New Zealand, and Australia. Whereas in the US, there's only one that's been FDA approved for any neuropsychiatric symptom in Alzheimer's disease, and that's brexpiprazole, which we'll talk a little bit about. In a 2019 network meta-analysis for antipsychotics for agitation, there was really no antipsychotic that outperformed the others. It was thought that Abilify may be most consistently effective compared to placebo, while risperidone might have had the lowest risk of death, and that both Abilify and olanzapine might have been best to actually reduce stroke risk, which risperidone is noted to actually have an increase in sort of stroke risk, leading to some of the black box warning that you might see. But with KD-AD, which was a large trial looking at atypicals in particular, you can see that there was an increase in mortality, stroke, extrapyramidal side effects, and UTIs even. And so because of that trial and quite a few others, a lot of the society guidelines on deep prescribing and on appropriate prescribing in older adults argues against using these medications. So it's not that they can't be helpful. It's just that you want to make sure that when you're talking with patients, they understand the risks and benefits. And I do think actually disclosing that there's a black box warning is worthwhile. My experience is that most families don't particularly mind, but they do find the information helpful. Pimavanserin, there is a randomized controlled trial for it. Certainly it's used for psychosis in Parkinson's disease. However, it was not helpful for agitation or aggression in Alzheimer's. Part of the thought was that those with severe psychosis might benefit, but really more for the psychosis piece than for the agitation or aggression. So even though I sometimes see pimavanserin prescribed people with Alzheimer's disease, there's not a great rationale for agitation. But you might think about it in someone with psychosis, especially if you're within the VA system who will pay for that. I mentioned brexpiprazole. Again, FDA approved for agitation and dementia. You can see that it did show a good signal. This is on the Cohen's-Mansfield. This is directly from the trial. What's hard to know about brexpiprazole is if it outcompetes Abilify or aripiprazole. The two medications are very similar, with brexpiprazole having a little bit more activity on the D3 and D4 receptors. How important that is for agitation control isn't clear to me. And so from the perspective of resources, you may not necessarily use brexpiprazole or Rexulti that much, especially if insurance isn't going to cover it. You might consider trying Abilify first. But another thing to keep in mind is that there was a Cochrane review on discontinuing antipsychotics. And in the case of mild agitation, discontinuing antipsychotics actually led to improved agitation. So keep that in mind for your antipsychotics, that even though you think they could be helping, reassessing whether they're necessary over time is reasonable, because there is some evidence that deep prescribing could help. So before I kind of go on to the rest of the case, any questions about any of this? I just threw a lot of info at you guys, but hopefully some of it kind of hangs on some of your clinical practice. Yeah, Brock.
Thanks so much. This is so helpful. And the question that comes up so often is as needed use. And so like I've got my kind of canned reply to that, but wondering if you could sort of give us your kind of take on what about antipsychotics PRN?
I personally love PRN use, and I'll explain why. For one, I have the suspicion that antipsychotics do very little for agitation control besides sedate, and sort of make people feel kind of like a zombie. I don't think that there's much special about them, and especially at some of the doses and some of the patterns that we use them in. I think that a lot of what they're doing is sedating before blunting will, especially with something like quetiapine, where doses we give it at are usually below, 200 and below, and they're not even having much D2 blocking ability until much higher than that. The other thing is that just from a risk standpoint with PRN usage, you are likely to mitigate some of the longer term side effects with some of these medications. The challenge, of course, with all of this is that almost none of it's been tested in clinical trials, PRN versus sustained use. And so from an evidence base, you don't have much to go on. But in my mind, if you can keep the dose low and use it as needed, it's better than giving a medication daily that can be harmful. There are obvious caveats to this, and I think those come around, with falls. I think they come around with things like if someone can de-escalate as it is, but they need prevention from de-escalation, then that's not, as helpful for the medication. But I will say that for PRN usage, I often try other things like gabapentin, trazodone, before reaching for a PRN antipsychotic. But I'm a big fan of their use over scheduled, but a lot of it will also depend on the syndrome that I'm seeing and what I think might be underlying it. So again, that kind of goes back to that DICE approach of really getting a good sense of what's underlying. So for instance, if I think that there's some degree of depression and anxiety, I might consider scheduling Abilify, which has some good signal in older adults with depression and anxiety, coming from one of the recent New England Journal of Medicine articles that came out in 2024, 2025 as an augmentation agent for Abilify outperforming even bupropion. So that, might be a consideration. If there's significant psychoses that I think that I can help, sometimes I'll reach for scheduled risperidone, again, for more of that prevention angle. So it really comes down to the patient and why I'm using, and why I'm prescribing it, what I'm hoping to get out of it, and kind of getting that. But I've got a lot of flexibility kind of built in from thinking about this a lot and doing it for a while. And so I probably outthink myself a lot of the times when it comes to PRN usage and things like that. I do think there's a role for it, though.
But I totally appreciate your perspective, and I think that in many ways you're right. I'll tell you sort of why when I sort of do my training for primary care, I sort of try to steer people away from PRN use, which is that because as you have so sort of like brilliantly done, the first, the second, and the third line are non-pharmacologic, and like we really should only be using antipsychotics for severe symptoms. And it gets tricky to say, oh, but as needed, if they have symptoms, it opens that door to, I think, kind of overuse, because it's just like easier to reach for, like, oh, we're just giving it this one time, as opposed to, no, this really should be reserved for persistent and severe situations. And also because, so much of the non-pharmacologic approach is all about, be patient with the symptoms, like you don't have to like reflexively immediately need to sort of treat an agitation episode, sort of, because a lot of times they pass quickly, and just sometimes just sort of being calm and stepping away and sort of letting the moment pass, like 20 minutes later, somebody's not sort of agitated anymore. But if you've already sort of like triggered this, like, oh, go get the PRN pill, and then, oh, go get them sort of to try to swallow the pill, and then, get it absorbed. Like often, like that's like a 3-hour PRN process. And by that time, this sort of like, inter episodic sort of moment has passed. And so you're almost kind of like sort of chasing somebody's tail by trying to treat sort of like a PRN sort of usage. And so that's why I asked. I'm so glad to hear your perspective, because I think that there are different ways to skin this, and so just sort of offering up sort of what my thinking has been about it.
Yeah, and I think that, one of the things that's really important about what you're saying is like reserve those antipsychotics for severe situations. So if you want to use PRNs, sure, just don't make it a PRN antipsychotic. Try something milder first. Try that really low dose gabapentin. Try some of the trazodone, especially like in an FTD type setting where there's some signal for that in the trials. You don't have to reach for the stuff that's an antipsychotic. If you want to try that, really reserve those for your severe situations, and then figure out accordingly, right? I agree with you. If you're spending so much time trying to administer the antipsychotic, or you're talking about episodes that come out of nowhere and last 10 minutes, PRNs are not for you. This is where some of that describing and investigating triggers and understanding what agitation looks like is really important. And I also think that as you communicate with other providers, a really important thing is don't tell another provider that there's agitation in the patient. That doesn't really tell you anything. It's not a disease. Tell them exactly what you're seeing. And similarly, when a family says, we're noticing bouts of agitation, they're often reading information online, they're hearing agitation's a thing. But what each person means by agitation is very different. So ask clarifying questions. Oh, you're noticing agitation. What specifically do you see? Can you give me an example of when you've noticed agitation? That'll often give you some ideas of the behavior that you're really seeing. And sometimes you may be surprised that sometimes what you thought was agitation was just motor restlessness. Sometimes what you thought was agitation was actually psychoses and fear. And sometimes it may be low blood sugar, and that they're really actually kind of out of it and listless. So ask those clarifying questions. So let's go back to the case real quick, unless there's any other questions. Cool. So initially the patient was trialed on sertraline for anxiety, but this discontinued due to diarrhea. And then she was switched to Lexapro 10 milligrams. And her primary care physician prescribed quetiapine 12.5 milligrams in the morning and 25 at night. But this led to drowsiness without changes in behavior. So then her neurologist switched her to risperidone 0.5 milligrams twice a day, as well as 0.5 as needed, and added Ativan at 0.5 milligrams as needed for aggression. And even though these were used sparingly, there were still these daily occurrences of agitation that were peeking through. So while the initial pharmacology was unsuccessful, a psychiatrist was then consulted. On an interview, the patient expressed that one of her caregivers had thrown her down the stairs, and so she was often fearful. But her husband later told the psychiatrist that this was a fixed delusion and did not occur. Despite this, it was true that when that caregiver was left alone with the patient, that the patient hit her and the police needed to be called. So, what are you guys noticing here? Good. So, yeah, they're going to end up with no caregivers willing to come to the home. That is something that can happen, and it is a concern. Um, but yes, it sounds like, when you start talking about violence towards caregivers, you're setting up an environment that where other caregivers, might not come to the home, or they might lose sort of the ability to work with certain agencies.
Hi, my name is Kyle. Thank you so much. I've been listening. I'm gonna go out on a limb, and I'm hearing it around the same person. So I'm wondering, did this person do something to sort of escalate a situation? I think we always assume the best, but maybe sometimes we forget, or we just aren't as good as we think we are in certain situations. So like maybe interrogating exactly what happened with the caregiver. Did they, it's usually something about going to the bathroom or putting on clothes or cleaning up or something, I feel like. And we're like, you have to clean yourself. And the patient's like, no, I don't. And so like maybe did they did they try to force something that the person didn't want? And this patient like reacted emotionally.
Yeah, absolutely, right? So is there something about this caregiver in terms of the way they're delivering care that is somehow rubbing the patient the wrong way? Was there a past incident that even if the patient can't recall necessarily, because you're able to get from collateral that that sort of thing happened? And that's a great segue into kind of the next slide where the patient notes that she feels very safe with a different caregiver and says that caregiver constantly puts me at ease. I'm at ease with her. The husband, in fact, agrees um, and says that the other caregiver often encourages physical activity, including taking the patient outside for walks and doing yoga. And also, that caregiver will stay calm in moments of agitation using a quiet voice and then often validating and redirecting the patient's concerns. So again, hitting very nicely on what is it about working with one caregiver versus another that's so different. And hopefully you're seeing embedded in this some of the non-pharmacological techniques um, that this caregiver is using, whether trained to do so or not. We don't know exactly, even though these were paid caregivers, how much training they had for working with people with dementia. But you notice that encouraging physical activity and engagement, staying calm in moments of agitation, using a quiet voice, but then also this idea of validating the emotion in front of you. So saying, I can tell you're feeling upset about having to take a bath, but then redirecting. But the bath's going to happen later. And right now, I'm really curious. Are you hungry? Do you want to get dinner? So trying again to trying to get off that topic, or especially I see this a lot where there's a fixed delusion. If you try to reality test her on that delusion, it often escalates. But instead of saying like, I hear that you're worried someone's in the house, and I can tell that you're afraid of that. I think that maybe we should go for a walk, though. We can get out of here, maybe get some fresh air. We'll feel better, right? I feel you. I understand that you're feeling this way, and then pivoting to a different topic, I think can be very effective to de-escalation at times. So during the interview, the husband accidentally puts his hand on the patient's hand as he was getting up, and she yelled out that it really hurt her, and she swatted at her husband, even though it was very brief. Afterwards, we discussed it with the husband, who said yes, he had just sort of lightly brushed her hand. He was getting up, and noted the patients can be particularly frightened with loud noises and that she's often on edge. Um, yes, so someone was talking about specific training and basic training being important. Again, get the idea of that person-centered care being important. What do you notice here with this interaction, though, at the end, where small stimuli, big reaction, seems to be on edge? Does it make you guys think about anything particular? Yeah, exactly. PTSD, like a trauma response. And so, while we don't know, I don't know what her specific trauma history was. And someone else saying, "Highly recommend a book on caregiver." Oh yeah, very good. Well, I don't know what her specific trauma history was. Certainly, she seems to be displaying some signs of hypervigilance. And so that kind of brought me to the next group of slides. So let's talk about, as we start going into some of our second and third line things. Yeah, any kind of touch in one type of reaction. Ouch. Yeah, I think the family's torturing her when clipping her nails. Yes. So again, so that hypervigilance or sort of an overreaction to very small things. Um, so when it comes to anti-epileptics and mood stabilizers, I think there's a couple things to keep in mind. So for one, and I see this on CL services a lot in the hospital, Depakote was found is likely ineffective for agitation and dementia. There are other reasons to consider Depakote for things like myoclonus, but for agitation and dementia, there is no good reason to think that Depakote works. And I see it all the time, and I see it fail all the time. I'm sure there's that patient out there that got better with Depakote, but for me, it is not one of the things that I reached for in terms of mood stabilizers. For lithium, there was the LIT-AD trial, which was a small, moderate-sized RCT. It did not seem to show benefit in that trial, though it may have been underpowered, and there may be certain subpopulations, like one that present with more mania-like features where it could be helpful. Otherwise, there's really just kind of cohort, small case studies, and small randomized controlled trials for some other medications like gabapentin, which I've talked about using a little bit because of its relatively lower risk, as well as some evidence of it being helpful in things like alcohol use disorder and anxiety. Lamotrigine and topiramate. Keppra, as you can expect, did not have had sort of mixed findings for agitation, and same with carbamazepine, and then Oxcar was found to have absolutely no benefit. Of these, I will say that just based on my own psychiatric background, depending on patient features, especially if there was a past history of personality disorder, I do sometimes try Lamictal for certain things, and then gabapentin I'm willing to kind of give a shot to. I don't often use some of the other ones out there unless there's other extenuating circumstances to make me think they have a secondary psychiatric comorbidity that was present before the neurodegenerative disease. But what about things like noradrenergic blockers? So certainly a lot of us are familiar with prazosin, where there was a small trial initially that showed good evidence, as well as propranolol and pindolol. One thing that you guys should be aware of, though, is that there was a larger phase 2 trial, which I still believe has not been published, called PEACE-AD, that did not show a benefit of prazosin. However, it was greatly impacted by COVID. Prazosin is one of the things I still consider for hypervigilance based on some of the PTSD literature and some of that initial findings. But I use it with caution, obviously, because of risk of falls. So I keep the dose relatively low, and there are some good algorithms for titrating that. And then 5-HT1A modifiers. So mechanistically, reduced occupancy might be linked to impulsive aggression, but there's an autoreceptor function, so it's not exactly clear. However, for things, there's one case report in a retrospective study that showed modest benefit for buspirone. There's one small open-label randomized clinical trial for tandospirone. But despite me seeing these used a lot for anxiety, I actually don't think that they're very helpful, but they are very low risk. And so I'm not a huge fan of Buspar, unless I think that just the placebo effect would be very helpful, in which case, it's hard to find a better placebo than Buspar. But in this particular case, psychiatrists kind of keyed in on the hypervigilance piece, and so tried prazosin. And she got up to 2 milligrams BID using an increasing schedule of 1 milligram every 3 days of increasing escalating doses. And during this period, she was transferred to an assisted living facility. So 6 weeks later, her husband noted that the transition to the facility had been really hard, but the patient was getting better each day. And he specifically noticed that she didn't seem to be on edge or as reactive as before. And the patient expressed that she wasn't as fearful, but she was adamant that she didn't need to be at the facility. The facility director said that she's often exit seeking, but he notes that otherwise she's very compassionate with the other residents. They've used the Ativan 4 times in the 10 days she arrived, but haven't tried any of the PRN risperidone. The staff suggested that her agitation increased often when her husband left, and so they requested that he not visit for a while so that she could get used to the facility. The psychiatrist was uncomfortable with this plan, but instead continued to stress that behavioral interventions are really important, validation, focusing on giving the patient a sense of purpose so that she remains engaged. And the psychiatrist even said, you might try the risperidone PRN instead of the Ativan if the situations are less acute. Despite the relatively good clinical visit, the patient disrobed and assaulted staff 2 weeks later, And then the assisted living facility dropped her off at the county emergency department and said she's not welcome back. So this, I think, is a scenario that a lot of us have seen played out. But noticing again, and I won't elicit feedback on this one because I'll try to get to as much through the case as I can. But you know, there's a lot of medications being used. The prazosin might have taken off some of the edge, but there were still obviously, times when people thought that the patient was agitated, though a lot of it, seemed to come with loneliness, needs not being met, those type of things. Um, and even when the clinical visit seemed like things were heading the right direction, you can get this bad news that a few days later, the patient's discharged. And so at this point, um, you start there was thought about other medications that are fourth and fifth line. And so one of the ones that's emerging is the idea of using dextromethorphan. So dextromethorphan targets multiple receptors, but especially as an NMDA antagonist. And when combined with something like quinidine or bupropion, due to its inhibition of the 2D6 CYP, it actually extends the activity of dextromethorphan to give it hopefully its helpful properties psychiatrically. So you might often see that, such as with Avelti, that it's bupropion plus dextromethorphan. The bupropion actually is not there for mood stabilization. It's there as a 2D6 inhibitor. So dextromethorphan with quinidine, I believe, is approved for pseudobarbital affect and ALS in Europe. And the randomized clinical trials have shown benefit in certain settings and not others. So there's two groups that have been doing this. One's Axisome with their bupropion combination, and then there's another group that does it with their quinidine combination. And so the ones with the bupropion combination had some positive-ish trials, whereas the ones using the quinidine had one positive, one negative trial. It still seems kind of up in the air about whether this is going to end up being helpful. But it is something that people are trying for agitation that occurs. But remember that and you can see in this graph, which comes from one of those trials, bupropion alone, not more helpful than placebo. It's the bupropion is there to extend the activity of the dextromethorphan. That's that AXS-05 drug. There have been some other things that have been tried. So Precedex has been attempted. There was a tranquility trial that was unpublished, but there's a press release suggesting that there was benefit. There are some reasons why it remains unpublished that have nothing to do necessarily with the actual scientific results being negative. And it may be helpful maybe for PRN use and in hospital settings, but it seems to be less clear if it's going to be useful for long-term maintenance, plus with the concerns that there could be falls. And then, of course, cannabinoids have been tried and been researched a bunch and continue to be. And while THC alone has no benefit, some of the THC analogs like dronabinol have some small trials showing benefit. And then outside the US, agomelatine, which is a melatonin agonist with 5-HTC 2C antagonism, has some improvement of aggression in small RCTs. I'm curious to see if it'll ever get to the US. But so you can see there are a lot of different things that are being tried, a lot of different things at your disposal. And for this particular patient, when they were admitted to the geriatric psychiatry unit, they actually removed all of her psychoactive medications. Gotcha. They stopped all of her psychoactive medications, including her SSRIs, and switched her to dextromethorphan, 45 milligrams daily, bupropion 100 milligrams daily, quetiapine 25 to 50 milligrams every hour. Yes, that is indeed what they wrote. But she only required it about once a day. And then they left the Ativan on as well for extreme anxiety when quetiapine failed. They trialed Depakote without effect, and her meds were crushed for increased adherence. They kept her for maybe about a week and said, great, your agitation is gone. And she was discharged from memory care and went to discharged to a memory care facility. The second she got there, the outpatient psychiatrist gets notes from the facility asking for more medication, just more. She's put on 25 milligrams of quetiapine TID, and as well as 25 to 50 QID for breakthrough agitation. And despite this, the memory unit still says, no, we want more medication. When meeting with them, they recommend increasing the bupropion, which is not an SSRI and can sometimes make anxiety and agitation worse in other contexts, despite the psychiatrist kind of mentioning that this isn't really appropriate, and that really it's there just to extend the dextromethorphan. The facility insists. And so the psychiatrist is ultimately willing to try this BID dosing of bupropion, but continues to remind the staff that patient seems to do better when engaged, has a sense of purpose, and encourages them to incorporate some behavioral interventions. So, you can notice that despite the short stay in an inpatient unit with temporary stabilization, there didn't seem to be a great plan for when the patient discharged. They were put on a medication that gives them half coverage for half the day in the morning, but not continued in the afternoon. And that reflexively, this new facility just wants their patients to have all of the antipsychotics or something, and they even said, or something stronger. So you can see some of the tension that happens as there starts to be multiple players in the prescribing, and that can be really challenging to navigate. And also you can see that as the behaviors are thought to be more and more distressing, that some of the consideration for behavioral interventions are lost, and that there's become just sort of increased focus on more and more medication. So the patient, family, and director of the memory unit then follow up 6 weeks later after increasing the bupropion. Now the director says that they've used Ativan almost every day, and they want it scheduled. Despite this, the psychiatrist has the memory unit actually fax their MAR, which shows that Ativan is used about 2 or 3 times a week, and primarily in a 1 to 2 week period. This is noted to the director, and the director gets visibly upset, calls the charge nurse, who then says that the patient has been more sexually promiscuous, disrobing, engaging in sexual activity with multiple new partners. And the staff reports that she's taken a new boyfriend, and though unfortunately that person is at a lower cognitive status, and so the staff is constantly having to remove her for issues of hypersexuality. So they're concerned for the safety of other residents. They note that on days when her husband visits, there do not tend to be agitation, and that she generally enjoys speaking with her daughters over Zoom. It's noted in the MAR that the PRNs are always given by 2 staff members, but never by other staff members who work with the patient. Agitation is always noted to be in the afternoon, never in the morning. So while the staff requests more Ativan and Seroquel or something stronger, the psychiatrist instead increases the dextromethorphan from daily to BID and restarts Lexapro. And again, the psychiatrist tries to talk about behavioral interventions, but the rest of the team's focused on medication. So again, what I hope you guys are noticing is not agitation all the time, but only in periods where medication's worn off because it has incomplete coverage. Again, a lot of pressure to increase sedating medications that are on the Beers list and that are dangerous. Clear signs that certain caregivers are working better than others for the patient. And though you don't always have control of who's on, and able to work with a patient, having some recognition that there are patient-centered factors that are helpful, but then also noticing that when the patient's engaged and is able to see family, agitation is less. So again, noticing what works for this patient. So inappropriate sexual behaviors can be a challenge. And so one of the things the psychiatrist did in this sense was restart the Lexapro. And in this case, it was less for its ability to help with agitation and more to try to reduce some of the hypersexuality. So bupropion can sometimes lead to hypersexual behaviors due to its dopamine and norepinephrine reuptake, whereas SSRIs tend to have more issues with sexual side effects. And in this case, you might be able to take advantage of some of the reduction in libido by something like an SSRI, which is part of why it was restarted. But as you can imagine, even though inappropriate sexual behavior is relatively common in dementia, so about 7 to 25% of those, there's really not great evidence for treating it. And so most of the evidence out there also focuses on men, and there are some interventions for men that may not be as appropriate for women. But again, stressing first-line behavioral interventions, changing the environment, even thinking about redirection, distraction. I've even heard of putting clothes on backwards, so disrobing is more challenging. And then other kind of engagement for prevention, and then also sometimes just some psychoeducation. So if a patient is engaging in masturbation or self-stimulation, giving the family or the staff some ability to say, like, that's a normal thing for someone to do. You know, there are ways that you can help perhaps facilitate that in that are going to be less disruptive, but realize that that's normal behavior for somebody. There's just a lot of pharmacology that's been considered. So SSRIs are considered to be first line by a lot of different experts in this area, again, through that sort of inhibition of libido, and then potentially even TCAs, antipsychotics are considered. Obviously, those have more issues for older adults. Gabapentin and carbamazepine have some case reports that are positive. Depakote does not. Um, cholinesterase inhibitors, there's some conflicting data. Um, and anti-androgens are beneficial, but ethically very questionable. Beta blockers for men might be helpful, and a couple of other very small things. So, um, what I'm going to kind of just leave you guys with, because we're out of time, is just some thoughts about when it comes to agitation and dementia, how you might consider thinking about the pharmacology. So again, if there's anything that you get out from the talk today, a lot of times when you're seeing agitation, it's in relation to an unmet need. There are behavioral interventions that are going to work best. Medication, even at its best, has a very modest signal. So be thinking about those things, be curious, try to understand when someone says that someone is agitated, what do they actually mean, and trying to come up with something behavioral. But in the situations where behavioral interventions fail, something that you can consider is one of these algorithms that came out of Harvard, South Shore. I don't necessarily endorse this as the only algorithm, but I think if you're looking for somewhere to start, this isn't a bad idea. You want to think about ways to decrease anticholinergic burden if it's there, and consider pain control. So don't forget about pain being a driver of agitation. Consider optimizing sleep and even using trazodone, especially at night if sleep is an issue. If you have initiated donepezil or memantine and it's indicated for that patient and their dementia, that's worthwhile to give a shot to. And then if you're reaching for something first line, consider something like an SSRI. Granted, this evidence came out before the SCIT-AD trial, but still considering Lexapro and sertraline as good kind of starting options, perhaps citalopram with some guidance about not going too far above 20 milligrams or considering an EKG if needed. And then, thinking about other things like second generation antipsychotics, even prazosin at relatively low doses. And then they suggest giving carbamazepine as one of the things, but I think there are other things that you might consider as you're getting to kind of that fourth line. So there's a lot of other things on these slides. Hopefully the slides can be posted for people to kind of go through some of the other cases. I know we focused a lot on agitation today, but I'll leave it for any last minute questions.
Thank you, Danny. And yes, absolutely. The slides and the resources that we've talked about will go out to our community and be posted. So thank you for that. Thank you for all the spectacular information. We do have a couple of minutes. Any other questions or comments? While people are thinking about that, I wanted to thank you also for the reminder. I tend to share that same kind of piece of these behaviors are this person's most skillful means of communication of an unmet need, and certainly not the way they would have communicated it previously, but this is kind of the best they can do with communicating with them. Something's not being met. I am curious, and maybe, again, if people need to drop off, I want to respect that because we are at time, but anything that you point care partners or other folks to in terms of training around non-pharmacological interventions? I mean, we've talked about STAR-C and a few other things here in other sessions, but any resources there that are your go-tos?
No, in fact, it's an area that I need to kind of think about more in terms of ways to kind of help people. I certainly talk to people a lot about the Alzheimer's Association. I know that at our clinic, we have a social worker that can often help. I describe some of the behavioral things that I would do myself about, how I'd use validation redirection, when I'm thinking about pain, ways to kind of, stay calm in those situations, trying things like soothing music, which I think has some decent signal from a behavioral perspective. Um, but no, I mean, I think that that's an area where I still need to learn more and have more things at our disposal. And it's something that as our clinic, we I hope that we continue to kind of think about is having some more formalized tools for this sort of thing. Um, I feel very lucky that I have a lot of the support from different types of staff at our clinic, but obviously, I'm in a very specialized, very privileged kind of situation in that regard. Um, and so I love seeing about some of these caregiving things that you guys have been mentioning as well, beyond sort of Alzheimer's Association, FTD, the AFTD, and the LBDA, which is often places that I'll go send people for some of the initial resources, depending on their disease.
All right. Well, with that, I'm going to share a quick slide here just as a thank you to our audience today. And just a reminder, cases, thank you so much, Danny, for including cases. I'm sure it resonates. It sounds very, very familiar, all too common. So, yep, cases, and then just a reminder about CME for any of our UW folks here. That is the process. It's in the chat also. And we, just another reminder, we do not have a session for the second week or the second Friday, our first session of August, but we'll see you back on August 22nd. And my understanding is that we had a little change in schedule, but we will be talking about blood-based biomarkers in primary care in anticipation of a larger discussion around blood-based biomarkers and other biomarkers later this fall. So look forward to seeing you back. Hope you all go out and do those fun things you were talking about, and see you next time.